The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone. This is the second ESSR webinar. And for today's webinar, we have imaging of osteoporosis and body composition as the main topic. Our speakers are Lucas Cofienza, Carmelo Messina, and Professor Giuseppe Guglielmi. And I'll hand you over now to, there will be an opportunity at the end of the webinar to ask questions. So please feel free to raise the hand option on the webinar tool. And I'll hand you over now to Professor Lucas Cofienza. Professor, are you there?
Yeah. Good afternoon, everyone. I'm Lucas Cofienza. I'm the Secretary General of ESSR, and I'm also here on behalf of the Italian Society of Radiology, the musculoskeletal section. Silvestri is the chairman, who wasn't able to come today. My role here just to welcome you. This is the webinar on osteoporosis and body composition, and it's a collaboration between the ESSR and the Italian Society of Radiology. So my role here is just to introduce the case presentation by Carmelo Messina, who is Assistant Professor of Radiology at the University of Milan, and Giuseppe Guglielmi, who is Associate Professor of Radiology at the University of Foggia. They will both discuss one case and then a lecture about osteoporosis and body composition. I hope that this relationship between the Italian Society and ESSR will be fruitful and will continue in the future. Thank you very much.
Okay, hello to everybody. I'm Carmelo Messina, and I will start the webinar with my cases. You probably already saw some images on the warm-up mail. These are basically some information about the patient. We are talking about a 61-year-old male with a long-standing history of spine pain and with a decreased mobility and stiffness. As a matter of fact, we also performed some tests, and the patient was negative for the HLB27. So we performed an X-ray study of the whole spine, and as you can see here, we see some clearly florid ossification of the anterior aspect of the vertebral spine. We see some incomplete bridging on the anterior aspect with some way that there is a preserved space, disc space. And if we move down to the dorsal spine, we start to see some ankylosis. Despite we still see clearly see the space, the vertebral spaces, and we see a very important ossification of the anterior aspect of the spine. Similarly, if we go down to the lumbar spine, we still see some very big ossification on the anterior aspect. It's like a digitation with the bridging, and again, somehow that these spaces are preserved. We see some ossification of the annulus fibrosus, and we also see probably some reduced lucency of the spine, which may be suspected for osteoporosis. We also performed an X-ray study of the pelvis, in which we see some other features that are quite interesting. We see some calcified endosopathy of several parts of the pelvis, such as the iliac crest, as you see here, the ischial tuberosity, and the greater trochanters. There are no clear bone lesion, and we see also some coxarthrosis on both sides. It's important in such studies to give a look, of course, at sacroiliac joint. In this case, we see that the space is quite preserved, but we also performed an MRI study of the pelvis, and here you can see that there is absolutely no sacroiliac joint involvement, with no edema, and with the space, the articular space, that is quite preserved. The patient was suspected to have osteoporosis, and we therefore asked for a bone densitometric study, which is basically the main clinical tool that we have in this case. As you can see here, if we look at both spine but also at the proximal femur, we see very high values, especially at the spine, of bone density. If we look at the L1, L4, we see basically that we have a 7.7 T-score, which means that this bone is 7 times healthier than the normal population. Of course, this is an artifact, and this is related to the important ossification that we have in the spine, which overestimate the BMD value, the bone density value. So in this case, we cannot really rely on the bone density, and we should go to different examination. Maybe we should examine the forearm, the distal radius and ulna, to see if we can obtain more accurate BMD value. Just 2 slides to basically explain what we saw. This is a diffuse idiopathic skeletal hyperostosis, also called as DISH, which is basically is called also Forestier disease. That is an arthritic condition, idiopathic, that is caused by excessive bone growth, and is typically located in the anterior part of the anterior longitudinal ligament. In this case, the disc space is quite severe, and there is no involvement of the sacroiliac joint. As extraspinal feature, we see that enthesopathy is one of the most common features. This can be seen, for example, in the pelvis, as we saw in the iliac crest, ischemic tuberosis, and greater trochanterus. The main differential diagnoses are related first with the ankylosing spondylitis, but in this case the ossification are thinner, they are vertically oriented, and they are always most continuous than the other side, than the dish, and there is almost in most of the time there is a sacroiliac joint involvement with a positivity of the HL-B27. Degenerative disease, of course, can be a possible differential diagnosis, but in this case we start to see some involvement of the intervertebral space with reduced space and disc degeneration. And of course, as a possible differential diagnosis, we also have to consider the fluorosis, but in this case, of course, we need to have an history of fluoride ingestion, prolonged fluoride ingestion. Thank you for your attention. I can give the word to Professor Guglielmi.
Okay, welcome to everybody, and it's my pleasure now to start this conversation regarding metabolic bone disease and osteoporosis in particular. First of all, I would like to acknowledge the support of Dr. Gomez and Zocchi in preparation of this conversation. Both of them are members of the ESSR and involved in the section of metabolic bone disease. As you know, osteoporosis is a skeletal disorder characterized by compromised bone strength, which predisposes the subject having an increased risk of fracture. As you can see from this schematic representation, when there are the interruption of the network among the trabecula, then there is a weakness of the bone, and this causes an increased risk of fracture. Fragility fracture are one of the most substantial challenges to public health system. You have to consider that across the world, the elderly represent the fastest growing age group, and a total of 20% of people living in Western countries are at risk to be affected. WHO organization consider osteoporosis to be second to cardiovascular disease as a critical health problem. just give some data regarding the demographic impact of this disease. Hip, vertebral, and wrist fracture are the most frequent fracture associated with osteoporosis. And the effect of osteoporosis on the skeleton is, however, systematic. And then there is an increased risk of almost all types of fractures. 4 million new fractures occur in Europe every year, and approximately 50% of women and 25% of men older than 50 years of age will have a fragility fracture in their remaining lifetime, with potential terrible result. From this graphic, you can see the incident rate of osteoporotic fracture by country. And on the top of this scheme, there are some region of some country of the northern part of Europe, like Denmark, Norway, Sweden, Ireland, and at the opposite, at the lower part, there are other continents like China, India. That means that there is a significant difference in terms of the risk. In fact, the first are colored in red, high risk, and the lowest in green. This means that there are some morphological aspects to be considered, and we will see during this conversation which one can be this factor that can affect and can determine the risk of osteoporosis. In terms of demographics, up of 25% of the subject with hip fracture will die within the following years due to associated morbidity. And approximately 20% will require permanent care. As you can imagine, all this condition will impact the social economic budget of every country, and also will have an immediate psychological and physical impact of every single patient affected by this kind of fracture. The vertebral fracture have less severe complication compared to the hip fracture, but are much more frequent. And only 30% of this vertebral fracture came to clinical attention. This is the reason why osteoporosis is called the silent disease. And the presence of one vertebral fracture increased 10 times the risk of subsequent vertebral fracture. In terms of cost, from this slide you can see that 36 billion euro in Europe and 18 billion in dollar in the United States cost this disease every year. And tomorrow the budget for this is estimated to be much more significant. Which are the conditions and the factors that can determine the peak of bone mass left life? As you can see, a significant role play the genetic factor, but also the dietary calcium intake, the estrogen, the physical activity, and the peak of bone mass reached in the intrauterine and the puberty are factors that influence the peak of bone mass at the age of 25, 30 years, and then consequently at the late life. As you can see, the equilibrium from osteoblast and osteoclast activity in osteoporosis is not kept, and in fact there is a lack of action from osteoblast activity, and there is a prevalence of the osteoclast disease, and this causes a continued bone loss, and this needs treatment. And now we have several options to treat this disease. But in order to treat correctly this disease, we need to make as soon as possible the diagnosis of osteoporosis to prevent the fragility fracture. And which are the technique, which are the modality as a radiologist we can use to assess bone strength? Imaging. So imaging is based, first of all, on the rule of different condition, different device that we are available, which should consider mostly two parameters. The parameters related to low bone mass, so bone quantity, and the parameter related to microarchitectural deterioration, so bone quality. So when we consider the technique available to determine bone strength, we have to think in these two different manners, bone quantity and bone quality. And using all the technique available, we will be able to make the diagnosis, to quantify bone loss, to characterize the bone loss, and monitoring therapy in the follow-up, because we can evaluate the efficacy of the treatment in the follow-up measurement of the skeleton. This is the armamentarium that every radiologist maybe can use in his her department. Conventional radiography, DXA, vertebral morphometry, and CT for sure are available in most of the department. Maybe quantitative ultrasound and the technique related to high resolution CT and MRI are less common, but we will also give a look on all of them just to have a panoramic view of the pros and cons of every technique. So the first tool available to make the diagnosis is plain radiographs. Plain radiographs is useful to grossly quantify bone density and microstructural change. However, when the radiologists make this diagnosis in the report, almost 20 to 40% of bone mass has to be lost for a bone to appear osteopenic in plain radiographs. So this means that the diagnosis made based on this evaluation on X-ray is late. So there is low sensitivity of the technique. And in addition to this, other technical factors can affect the appearance of bone, like sovra or under exposition of the skeleton. And also, we have to consider that the inter-observer agreement is not good due to different experience among radiologists. So the data coming from this evaluation are not reproducible at all. We have the advantage to perform this study at the level of the axial and peripheral skeleton, and now we will analyze in some details what can be the information that can derive from different areas. If we consider the hand, because the hand, you know, is an expression of every systemic disease, from this side we can analyze the cortical and the trabecular pattern of the bone. And in particular, we can analyze the thinning of the cortical and the widening of the marrow space. So if we have very high resolution film of the hand, like industrial film of other technique that can increase the resolution of the hand of this anatomical site, now we can look also in particular of the level of the cortical, intracortical and subperiosteal side of the hand. Moving from the hand to the spine, using this grading score called Saville, we can have the possibility to analyze the disposition and the lack of vertical and trabecular bone that give at the end of stage of the disease the so-called aspect of the empty box of ghost-like appearance. And from this score, the Saville score, we can also define the appearance of the vertebra in terms of the wedge, biconcave or collapsed vertebra. And this again is the Saville score. Moving from the spine to the hip, using the same index, we can also evaluate the trabecular and tensive arch of the trabecular at this anatomical site. And moving from grade 6 to grade 1, we can also give a score regarding the status of the resorption of the trabecular and tensive, compressive and tensive arch of the trabecular at this anatomical site. And the same evaluation can be done at the level of the calcaneus, because using this Giamaria index is possible also at this level to analyze the comprehensive and the tensive fascia of the trabecula that make the normal condition or to very low density of trabecula at this anatomical site. Going back to the hand, the new modern system using radiogrammetry and radiographic absorptiometry are able in detail to evaluate the condition where the cortical anatomical site more than trabecular is involved, and especially in this secondary hyperparathyroidism, the use of this technique at the level of the hand can be particularly useful. When we move to the spine, the presence of fracture should be reported in our radiological report. But this is a problem because several studies from the first paper written in the year 2000 until the more recent one have recognized the fact that recognition and reporting of vertebral fracture in a clinical setting as well as radiological report is a problem. And because of this, the International Osteoporosis Foundation has created several calls to action in order to increase the knowledge of this problem about radiologists and clinicians working in this area. As you know, due to different experience in the operator, the diagnosis of osteopenia on spinal radiographs is based on the qualitative evaluation given by the singular radiologist. And if there is not any problem in recognizing a fracture of the vertebra when it reaches this status of the disease with the shape of wedge fracture or concave or biconcave, maybe can be a problem to recognize the initial vertebra fracture when only a small percentage of the vertebra is affected by this decrease of density and then decrease of structure that lead to a deformity of the vertebra. But talking about deformity, we should also consider that not all the deformity are vertebral fracture. And that's why it's of fundamental importance that the radiologist dedicated to this report is recognize the Scheuermann disease and other conditions that are deformity that are not related to vertebral fracture. Because of this reason, in order to help radiologists in recognize and quantify, or at least give a semi-quantitative evaluation of the vertebral fracture, Professor Genant and his group created this scheme recognizing the wedge, the concave, biconcave, and the crash deformity of every single vertebra, based on the reduction of inferior to 20%, more than 20%, between 20 and 40, and more than 40%, that can create a score, grade 1, grade 2, and grade 3, that give an idea about the gravity, about the extension of the disease, and this should at least reduce the inter-observer variety in reporting vertebral fracture in radiological report. Other method, more recently, has been proposed to make a semi-automatic quantification of the vertebral height, and in this example, you can see a system that in a semi-automatic manner, from T4 to L4, make a contour at every single vertebra and delineate the anterior, the central, and the posterior height of every single vertebra acquired in a lateral projection. And naturally, since this is a system based on the raw data collected by the program, if the radiologist is not in agreement with the contour made by the system, then the radiologist can adjust the contour, because maybe in the delineation of the contour are taken the osteophyte, degenerative osteophyte of the spine, and this should be avoided in order to reduce false interpretation. Also, the DEXA system in the last 10 years has been also equipped with a system that in a semi-automatic manner recognize the fracture of the vertebra, but again, this structure should be interpreted by radiologists, first of all, to define if it's a benign or is a malignant vertebral fracture, and then report this in the skeletal, in the radiological report. So moving to the simple plain radiogram, there are too late make the diagnosis, we should move to another technique that is much more productive in terms of result. In fact, DEXA, that is the acronym of dual energy X-ray absorptiometry, is now the most widely used technique for the bone densitometry in clinical study as well in the research context, because this technique gives extremely low radiation dose, is a rapid scanning time, is widely available, and is a good reproducibility among the different measurements. And so is the technique that at the moment is recognized by WHO organization and is considered the gold standard in determining bone strength and fracture risk. Just giving you few information regarding how the techniques work. This is two X-ray beams which different kilovoltage that allow the subtraction of soft tissue from the bone of the anatomic region analyzed, and involve only low radiation dose, and this bone mineral density obtained by DXA correlate well with the biomechanical parameter which characterize bone strength. How works the machine and how are the parameters that are necessary to interpret the results of this BMD. First of all, we have to tell that is a bidimensional measurement taken at the level of the spine, proximal femur and distal radius, and so the result of BMD are expressed in terms of gram per square centimeter. The parameter obtained by DEXA measurement are the T-score, which is the difference of the patient actual BMD compared to the peak of bone mass reached at the age of 25 years, and the Z-score, which is the value of the patient, BMD patient, compared to normal age-matched subject, normal age, having the same age but normal. So, based on these three categories given by the WHO organization, we can create normal, osteopenic, and osteoporosis subject based on the result of the T-score. So, if less than 1, normal. Between -1 and -2.5, osteopenic. Below -2.5, osteoporotic subject with fracture, if there are fracture also on the DEXA report. Which side to examine? As I mentioned before, femur and lumbar spine are the most common anatomical side. But if sometimes it's not possible to analyze due to prosthesis or due to other metallic implant or other conditions that can affect bone metabolism, also the ultradistal radius is a useful site to examine. But when we talk about DEXA, we should consider that using this technique, there are several pitfalls because degenerative change, elevated BMD can projected classification can determine a false increase in BMD result. And also, not only subjects having low T-score with DEXA are at risk of osteoporosis or have a fracture in their radiological study. So, this means that other factors need to be taken into consideration independent of BMD to determine the risk of fracture. So, because of this, has been created the FRAX tool, which is a system that calculates the risk of fracture in the 10 years probability, and these are the parameters taken into consideration when we fill all the data necessary to have a result from FRAX. Age, gender, weight, height, previous fracture, parental hip fracture, smoking intake, glucocorticoid, rheumatoid arthritis, other causes of secondary osteoporosis, and alcohol intake. There are two main FRAX systems. One is the so-called UK model, based on the clinical information, and based on this clinical information, we can determine if the subject is at risk, high risk, low risk, intermediate risk, and then there is a cascade of the action based on this clinical information. The other system is the US model system that is based on the result given by DEXA. So not clinical, not information, but DEXA result. And from this, again, there is a cascade of action which consider normal, osteopenic, or osteoporosis, and we can move on this different direction just using only the T-score result. But T-score FRAX is not used in patients that are taking drugs, pharmacological treatment, and the FRAX-based treatment can vary country by country, and so there is not possible to apply this system in every place with having the same result. So because of this, again, the idea that something different from quantity of bone is necessary to determine a complete evaluation of the risk of fracture, and this is the bone quality. How we can obtain this bone quality? First of all, using the quantitative computed tomography technique, because with CT we have a volumetric evaluation of the trabecular compartment of the bone, and because of this the results are expressed in terms of milligram per cubic centimeter. So we have information regarding trabecular and cortical bone. This is an example of how the technique works at the level of the spine. The patient is positioned in the gantry, and with this method again we can avoid the superimposition of soft tissue and having a real true volumetric BMD. But when we consider this, we should also consider the risk of high dose administered by QCT compared with the dose that are irrigated when we use DEXA. In the new volumetric spiral QCT system, it's not necessary to analyze only for vertebra, but the entire volume from L1 to L3 are considered, and then we can have, using this, a complete evaluation of the trabecular, cortical and integral part, in this case of the spine, in the coronal, axial and sagittal plane, as well at the level of the femoral neck, and having also information regarding some biomechanical parameters which we will see later. So the region we can evaluate with CT at the level of the femoral hip are femoral neck, trochanteric and total region. So we have for sure a very good advantage compared to the bidimensional areal measurement obtained by DEXA, because we can use this in every CT system, and we can have again a separation of the evaluation of the trabecular and cortical bone. But, and also we can use this in some opportunistic study, because we can obtain this BMD measurement when we perform abdominal study of the patient. So using a phantom beneath the dorsal of the subject, we can also evaluate the BMD subject, the BMD of this patient. But we have to consider the fact that the radiation dose is significantly higher than compared to the dose irrigated with DEXA. And also we have to consider that when we use CT, we can't refer to the T-score and Z-score parameter that we use for the BMD evaluation done by DEXA. But when we perform CT, we have to consider a kind of cutoff value, and so below 50 milligram per cubic centimeter, we talk about severe increased risk of fracture, between 50 and 80 moderate increase, and above 110 normal, between 80 and 110 mild increase of risk of fracture. Another technique that we should mention is the quantitative ultrasound, a radiation-free technique that at the beginning of when appear in the market have a lot of interest because of the characteristic to be widely used without any risk. But there are some parameters, because it's true that we can consider the speed of sound, the attenuation, the amplitude-dependent speed of sound, and we have proven that there is a significant correlation with X-ray and the value of speed of sound and attenuation at the finger phalanx. But the device on market use different parameters, and so it's not possible to standardize the result obtained with this different machine. Because of this, there is not completely agreement in the community, and that's why at the moment the quantitative ultrasound evaluation is a little bit apart, waiting for the more agreement regarding the use of this technique. Another parameter that measures the quality of bone is the trabecular bone score, which is a parameter can be derived by the DEXA, and this parameter gives us an idea about the texture analysis of the spine. And in this example, I have shown the case of two subjects having the same BMD obtained by DEXA, so 0.9, that is 0.97, 0.96, equal in the two subjects, but one subject has a TBS 1.4, which is normal, and the other subject has a TBS value 1.2, that is significantly different from the previous, and in fact, the second subject is has a risk of fracture because it is an altered trabecular bone, and because of this, we can demonstrate that TBS is an additional parameter that can help in distinguish subjects which are not separated using only the standard BMD assessed by DEXA. Another parameter given by the last generation of DEXA device are the technique based on the active shape model. And this active shape model can be applied at the level of the hip, because consider the hip axis length, and this is the reason why the people, the inhabitants of the north part of Europe have a very high risk of fracture at this site compared to the Chinese, to the Asiatic people, because the configuration and the morphology of the hip is significantly different in the two populations, based on this measurement of hip axis length. Another parameter that can be extrapolated by the QCT is the measurement of the anterior, central, and posterior part of every single vertebra using this software applied on the 3D QCT. And talking about prediction risk fracture, this system can recognize and separate the recent fracture, the new fracture, and the old fracture based on the characteristic of the morphology that the system can recognize. And naturally, if we move from this morphological evaluation to the biomechanical evaluation using the finite element analysis, so going into details of every single component that make the trabecular bone at the level of the spine or at the level of the femur, we can have information regarding the strength of the bone. So, another possibility, looking at the quality of bone, can be given by the high-resolution technique. First of all, we evaluate high-resolution QCT at the level of the peripheral bone, so at the level of the ultradistal radius or at the level of the tibia, and then you can see that with this technique we have the possibility to evaluate the trabecular compartment of the bone, but also in particular the cortical bone, and separate in this the endosteal, intracortical, and subperiosteal compartment. They are very important for some disease having a high turnover rate, and so because of this they affect especially cortical bone. Another technique that is very, very important, having a lot of interest, especially for research, is the high-resolution MRI technique. And here you can see the possibility to analyze the trabecular network as well as the cortical bone at the level of this distal radius or tibia. And also using some advanced MRI imaging is possible to create using particular sequence to start to mapping proton density and spectroscopy have information regarding the status of every single part of the vertebra or the femoral neck. And in particular, if you use this particular sequence, you can see how at the level of the calcaneus, that as I mentioned before, has the same disposition of tensive and compressive arch of trabecula, you can see in this very high resolution imaging the degree of normal of osteoporotic condition. But again, we have to consider that MRI is not available for this kind of study, because this study are done especially in the research center and need a particular knowledge about the radiologist working on this. So the last technique I have shown demonstrate that are able to improve significantly the therapy and the diagnosis of the disease at early stage, but since are not widely available, at the moment they are not proven and not possible to be used in clinical practice. So at the end of this first part, I can conclude telling you that to reach the goal of making an early diagnosis of osteoporosis and to determine the actual bone strength, and this to have at the end a really reliable fracture risk prediction, is important to integrate the parameter came from bone quantity, for instance from DMV, with parameter came from bone quality that give us information regarding the microstructural property of bone. And among these, we should remind TBS, we should remind QCT and high resolution QCT and high resolution magnetic resonance imaging. The last few minutes of my conversation will cover another aspect of this talk that is regarding the body composition. Using whole body DXR, as you can see, we can measure regional change in fat, lean, and bone. And if we consider this picture shown in this slide, in 3 months, we can have on the same subject a really possibility to determine the reduction of the fat component regarding the increase in lean. So 3 months are good enough to demonstrate change in the body composition. How works the system? How came the information for this analysis? First of all, the DEXA recognizes 2 main regions. Android region, located at the top of the pelvis, and gynoid region, located below the base of the android region. So, to differentiate the shape of female and male deposition of fat, because we can recognize these 2 kinds of deposition of fat, the so-called apple shape in man and pear shape in female. And you can see in this scheme how the deposition of fat take place. But when we recognize that there is a deposition of fat, we should go into more details to determine which kind of fat we are talking. And so we should recognize the subcutaneous fat from the visceral fat. The subcutaneous fat is comprised about the fat that is around the muscle of the abdomen, and in this case you can see two subjects having the same body mass index but totally completely different proportion of the fat, because in the first case there is most of the visceral fat, and in the second case, having the same BMI index, the second subject has a very low visceral fat but is very high proportion of subcutaneous fat. So again, using CT, we can separate the proportion of visceral and subcutaneous fat. And why recognition of subcutaneous fat versus visceral fat is so important? Because visceral fat, which is the fat in and around abdominal organ, has been demonstrated that play a significant role for all-cause mortality in men and women, because it's associated with the so-called the metabolic condition, because it's related to deposit of triglyceride, cholesterol, hypertension, and cardiovascular disease, and fasting glucose. So the position of fat at the level of visceral fat is important, because give us an idea regarding the risk of cardiovascular disease and in what is called the metabolic syndrome. This is again how the system works to separate the inner abdominal muscle wall and the subcutaneous fat. And again, then when the scan recognizes the region, then the system play automatically some region of interest using the software to separate in the two regions. And you can see that after the follow-up, a subject having this proportion of fat and lean mass in 8 months can be completely monitored and followed, and in fact the proportion of lean and fat and percentage of fat change following a therapy. So this is important, because this system, with this information, we can monitor weight change with DEXA body composition in less than 1 year. In conclusion, the assessment of body composition play an important role in nutritional evaluation in clinical setting for the quantitative measurement of tissue characteristic over time, between fluctuation in body composition equivalence in relation with survival rate, clinical condition, illness, quality of life, and bioelectrical impedance analysis. Of consequence, monitoring body composition is very important for nutritional and medical intervention. And I spent the last 2 minutes of my presentation to inform you that under the umbrella of the European Society of Skeletal Radiology, as well as the Italian Society of Medical Radiology, and in particular of the section of musculoskeletal, we are organizing the 4th edition of musculoskeletal imaging of winter school next year from 21st to 25th of January. This year, the faculty is composed by Professor Philip Van Acker, Professor Mario Mas, Professor Luca Maria Sconfienza, and Dr. Bazzocchi from Rizzoli Institute, and this is an overview of the talk that characterize every single day. And you will receive more information very soon from the website of the ESSR, because I'm sure that you can you will have the possibility to connect with the website of the University of Foggia, and over there you will see all the information related to the course. And with this, I hope completely on time, I have concluded my presentation. Thank you for listening. Judith?
All right. Thank
Okay.
you, Professor Guglielmi. On behalf of the webinar organizers, the moderators, and the Young Club, thank you for such an informative and comprehensive overview of past, present, and the future directions of osteoporosis imaging, which is becoming more and more important with our aging population. Thank you, Carmelo, for your excellent case, and thank you for keeping to time. We've had an excellent turnout today, so please provide us with feedback to help us improve and develop this new educational tool for the future webinars. We now have time for a few questions, so if you could please raise your hand using the tool on the webinar, and if you have a working microphone, feel free to direct your questions to the speakers, and I will unmute you. So, are there any questions for the speakers?
Fine.
Yes, okay. We have a Jacob Oman. Go ahead. Jacob, are you there? Doesn't seem to have his mic attached. Okay, let's move on. Has he asked a question on the... Oh, so we have a question from Etienne. Oh, Jacob, you're there. Go ahead, Jacob.
Yes, hi, Dr. Uman, Jacob Uman from Manchester. Just a quick question. What percentage of your patients are on teriparatide treatment rather than bisphosphonates?
Sorry, what is the question? I can't hear it perfectly.
What percentage of your patients are on teriparatide rather than on bisphosphonates?
What is the risk of patient with diphosphonate having osteonecrosis, you mean, or fracture?
Yes, I mean, those who have had multiple fractures, are you in favor of teriparatide compared to bisphosphonates?
Okay, this is a question related to the therapy, to the drug. Yes, my experience is that we have much more experience in giving bisphosphonate, but due to the side effect of this therapy, when we administrate bisphosphonate, we continuously check the status of the jaw and ask for odontoiatric colleagues to evaluate clinically and after with orthopanoramic view of the jaw if there is any risk of having this osteonecrosis at the level of the jaw. And also we consider the fact that with kind of therapy we can have risk of fragility fracture of the long bones. So we follow the patient and clinically ask if the patient with a phone call interview or with periodically visit in our center if there are any symptoms or any problem that can alert us in continuous or interrupt the subministration of bisphosphonate. Okay.
I was concerned that bisphosphonates in an elderly patient, I'm talking about above 80, if bisphosphonates is used to suppress the already dying or dead bone, it's not going to help, is it? So bone anabolic agents are more useful rather than bisphosphonates in treating elderly patients?
Yes, yes, but again, this is a decision that is taken among other colleagues of the group, because we have a osteometabolic group which include endocrinologists, which include orthopedics, which include rheumatologists. So regarding this specific aspect of the therapy is something that we discuss in this unit. It's not a decision that is coming only by radiologist or another single specialist, but it's a decision based on the common evaluation of the single patient. And in this context, the presence of endocrinologists and the gynecologists and orthopedics is important, because it's a common and sharing decision. So depend on the case.
Can I ask one last question?
Great. Sorry, we're going to have to move on because we have quite a few questions, if that's
Okay.
all right. Thank you, Dr. Uman. Thank you so much.
Okay.
Okay, one more, Professor. We have a question from Rabé Etienne saying, Professor, what is your approach to DEXA scans in young patients and children?
Okay. As you know, it's necessary to have the program for the pediatric and also for newborn children. In our center, we combine the pediatric scan, and so we use only the Z-score parameter, using other parameter like Tanner index and other parameter biologically, which give us a complete idea about the growth of this skeleton. And then with pediatric in this case and neonatologist, we apply this study of whole body, or depend of the age of the hip, of the spine. But again, using system DEXA software dedicated for pediatric. So with having the normative data collected by pediatric population.
Fantastic, thank you. We'll just take one more question. We have a hand up from a Gabriella Toma. Are you there, Gabriella? Gabriella, you're now live. Do you want to ask the professor a question? If you have a microphone. No? Okay, we will move on. We have a question here, Professor, from what about the determination of osteoporosis in CT obtained for other reasons by Francesco Peruzzi? So do you determine osteoporosis with CTs obtained for other reasons, Professor?
Sorry, can you repeat the question?
The question is, what about determination of osteoporosis in CT obtained for other reasons?
Oh, what are the rule of this opportunistic use, you mean, of...
Yes.
Okay. Is well demonstrated that in order to reduce the exposition of subject, because already mentioned the fact that there is higher dose administered by CT, using a particular software and the use of a phantom, you can have information when you perform CT for other purposes. And also has been shown that the use of contrast media, because if you study the abdomen of the chest of subject, you for other proposal like for tumor, hemomyelolymphopathie or other condition, then you may need the use of contrast agent. The use of this contrast agent has not significant rule in affecting the measurement of BMD at the level of the trabecular bone of the spine. And so, because of this, I suggest that if in a center there is opportunity to ask and obtain a phantom that you can use contemporary with the other exam taken for different region, then the data coming from this exam you can use to extrapolate the risk of fracture for that single patient, having in mind the fact that, different from DEXA, you should not refer to T-score or Z-score, but you should refer to the 3 cutoff value that I mentioned talking about CT, and so below 50, between 50 and 80, and above 80 milligram per cubic centimeter, which represent the 3 cutoff value to evaluate a subject using QCT.
Perfect. There is another question, Professor. Which score do you use for men's DEXA, T-scores or Z-scores?
When we use both data, but naturally, as I mentioned before, for pediatric we use Z-score, but for adult we use T-score, and the WHO criteria is based in the T-score value to recognize normal, osteopenic, or osteoporosis subject, as I mentioned before, based on the value -1, between -1 and -2.5, and below -2.5. So the T-score are used for adults, for pediatric Z-score.
Excellent.
Okay.
Okay, just looking if we have any other questions. We have one question. Dr. Oman again, go ahead.
I was wondering if you still use strontium for treatment of these patients.
Which drugs?
Strontium.
Strontium? No.
Yes.
No, we don't use this.
Okay, fantastic. Thank you.
Okay.
Perfect. Okay, so thank you once again, Professor Guglielmi. So we look forward to welcoming you all to the next webinar, which will be in November. This will be given by Dr. Eva Lopez from Valencia, Spain. And she'll be presenting on the imaging of tendons and ligaments of the ankle. And this is again free for ESSR members, so please register on the website and please provide us with any feedback. My colleagues who also co-moderate with me, Dr. Adriansen and Dr. Maria Tazolniku, we will do our best to improve webinars as best we can and bring more great speakers like Professor Guglielmi. And thank you for your time. And by this, I will end the webinar.
Okay. Thank you for listening, and good evening to everybody.